Good afternoon and good evening, everybody. Thank you for joining the next instalment in the Linking the Spine Community webinar series from Medtronic. Today we're doing a webinar titled A New Era in Spinal Deformity. We've got two excellent faculty from the United Kingdom, one from the Northeast with Mr. Andrew Bowie and one from the Southwest with Mr. Ian Harding. So without further ado, I'll pass you over to Mr. Harding to kick us off. Thank you.
Thank you, David, and thank you for all of you for coming on board this evening. We'll hope you'll find this informative. I've been asked to give this title talk based on adult deformity in particular, and it's really a view of my own personal views based on experience and of what we know from studies, etc. So we face lots of challenges in adult deformity, there's no doubt about that. And they come in many shapes or form, and I'm going to have to gloss over some things, but concentrate on some very key things that I feel are most important in the assessment, planning, execution of the surgery, and then preventing complications. So general principles that I follow, and this may seem basic, but I think it's really important to always come back to these things, that you can't say one size fits all. It never does. You have to individualize things. I think rules are there to guide you. They're guidelines. They're not tram lines. And formulae, likewise, they're not cut in stone, and you can't be too prescriptive about things. You have to think about age. You have to think about the fact that the spine moves. It's a dynamic thing, and people move. So when we fix them, we fix them in one position. And we also need to think about how long has that patient coped with that deformity, and if we do something too radical to them, how they're then going to adapt afterwards. And above all, don't just think about your own goals as a surgeon, making the X-ray look better, but think about the overall goal for the family and the patient and all the other healthcare workers. So now on some nitty-gritty. Rules of alignment. Now, alignment is a very static concept. And I think, it's not the aim of this talk, but I just need to highlight that you need to identify patients where they've got a low incidence or a high incidence. That's really important. You need to accept that most patients have their lordosis low down. You need to accept and understand where the patient's lordosis transfers into kyphosis. The shape of the lordosis is also really important. So is it uniform? Is it asymmetric? Where's the apex? How long is it? And as I said before, you need to accept that fusion is really non-physiological, and putting the spine in one position may suit that person for a moment in time, but may not suit them at other times. And then compensations become very important. So static clinical assessment, this is just some very simple basic things that I think are important to look at in clinic when you're seeing patients, not necessarily to rely on x-rays, but see how the patient's hips, knees, pelvis, and thoracic spine, and even cervical spine adapt to their spinal deformity. And you can do some very simple tests to look at that. This is an often used image and a concept that everybody's spine is different. We all know that now. That's old news. But what you mustn't forget is that everybody's spine is different, but it always moves. And so the x-rays you see here may be very different when the patient's sitting, we know that, when they're moving, when they're walking, when they're tired, all those things. So thinking about a fingerprint for each patient is important, but not everything. This is just exemplifying when how lordosis can be different in patients. Now, if you follow the tenet that lordosis goes from L1 to S1, I would suggest that you're going to end up in trouble. It's a good place to start, but it's not everything, and you have to think a little bit out of the box. So sometimes the lordosis can be long, sometimes it can be short, as you see on the right here, and sometimes it can be almost impossible to decipher, such as on the left. The apex varies as well, so the same 3 x-rays. If you look at the apex here of the lordosis, in the middle picture, the apex is probably up here somewhere, whereas on the right one, the apex lordosis is through the L5 body, so it's very important for your rod bending. And then symmetry, is it symmetrical? So are the arcs of lordosis, do they match up? Is the upper and lower arc the same? Well, clearly here you can see it's very different in different patients. Now, when we think about patients, we need to think about where they are in their life. So if we look at normalized data, as in lots of the papers from 10, 15 years ago about where people should have their spines at any given time, then it ignores the fact that with time, your spine changes shape with degeneration. And so do you really want to be putting a 75-year-old lady into the position she was in when she was 25? And I would suggest you probably don't. And people have, this is a sort of a very complicated diagram exemplifying the fact that patients' sagittal parameters change throughout life. An important thing to accept, but not necessarily to follow prescriptively when you're planning your operation. And that brings me on to formulae. So we often talk about incidence lordosis mismatch. And I think that's a good rule. You know, low incidence means low lordosis, but it's so simple that it's too good to be true. And it is too good to be true, because you have to have the right shape of the spine and all those factors I've just mentioned about length of lordosis right. And so for me, it's just a question of big lordosis. So a big incidence means big lordosis and vice versa. And I think there's real issues I have, particularly with using a formula that goes from L1 to S1, and you have to be very careful about it. But if we don't get some of the basic rules right, building enough lordosis in, putting it distally, thinking about contour of the rod, not just the overall lordosis, and accepting the fact that some patients may need their spine in a different position to others, we can lead to big problems with what we do to patients when we fix them non-physiologically. And these can be adjacent problems above the construct that we all know about, but also within the construct itself. And in this talk, I'm going to talk about why I particularly use 3 or 4 rods, and we can have construct failure, which is unfortunately extremely common in adult deformity. And it's common because of these things. It's common because of patient factors and surgeon factors. And the old thing we all learned when we were starting out in spine surgery about mechanics and biology. So when we're planning, the idea is to get it right first time. So a phrase we use in the UK lot, and you may say this is impossible because we don't actually know what we're trying to achieve, but we must do our very best. So we need to decide, are we going to use nuts and bolts or are we not? How long we're going to make a fixation, how dense our implants are going to be, what implants we're going to use, do we need cages, do we need secondary, tertiary, quaternary rods, and are we going to osteotomy? So many questions to decide and so many ways of cooking an egg. Some basic things though, so if you do a longer fixation, you're going to have a higher pseudoarthrosis rate compared to a short fixation. You need to avoid using a long working length, i.e. you need to put screws in at each level to limit that. And I think it's really important to get overall good global balance, because if you have any slight imbalance with a long lever arm, it'll lead to high failure rates. In elderly, of course, we've got really soft bone. And in elderly, there's a definite trend towards higher density fixation. Personally, I don't use adjuncts such as cement or fenestrated screws or anything like that. And believe that the right way forward for people that are older is to put in probably more implants if you're going to operate. And that's the key thing, whether you do or not. There's definitely a trend towards stiffer constructs, and whether that's right or wrong, I'll mention shortly. So rod contouring is vitally important and very difficult, because we don't exactly know, if we put our hand on our heart, what exactly that patient needs at every moment of their life. It has to be different at different times. It can be a lot more challenging in cobalt chrome, and you do have to take a lot of care when you're using polyaxial screws in the context of deformity. Around the lumbosacral junction, it's absolutely vital that you get the right amount of lordosis. I mean, big or small, and that you can achieve this using interbody cages via various different approaches, which is outside the context of this talk. As is how you do your fusion. And of course, you can see here, interbody fusion is, of course, the best way of getting fusion, but in elderly patients, interbody fusions may collapse, subside, and may not be the right way forward. And so you may think about using multiple rods. Likewise, biologics may be something you wish to consider, but again, not something that is in the context of this talk now. So I'd like to really concentrate on why I use 3 or 4 rods and in what concept. And those of you that have been using it will probably be developing your own techniques of using them. And in all honesty, I'm learning and I'm developing different techniques and methods of how I use multiple rods and why I use them. And my practice has changed a little bit since I started using them a few years ago. So you can use an auxiliary rod in long constructs or just across the lumbosacral area. There's a kickstand technique which I'll show shortly. And I tend to always use multiple rods across a 3-column osteotomy, whether it's a PSO or a VCR. And it's also particularly useful in revision surgery. And when I'm doing multiple rod techniques, I often use this double-headed polyaxial screw, so-called DR Mass, which is on the Solera set provided by Medtronic. And this enables me to use rods very easily, 2 rods, and it gives me lots and lots of options. And we've also got, as you'll see on the screen here, a variable angle domino if you want to just add a 3rd or 4th rod onto a conventional system using a single headed screw. Now, what we don't know is the right combination of rods to use, whether we use titanium, all of them, cobalt, chrome, and titanium, where we put the double-headed screw, do we put the main head above the shaft, medial, lateral? And these are all things that you learn as you pick up, but it does need quite a bit of experience with them to make sure you get it right, particularly when you're doing an osteotomy and using the controller, which I'll show you now. So I think the best way to illustrate some of those principles is to show you some case examples. And here's a patient, and just highlighting principles that I feel are important. And here we have a patient who has a low pelvic incidence and a so-called, what I believe a type 2 Russelli spine, although one could argue a type 1, type 2, but I think this is a type 2 with a globally distributed lordosis, which is low because the incidence is low. But in this case, the patient has multi-level stenosis with degenerative spondylolisthesis and is very young, and so has got good bone. And this is something that we've kept an eye on for a while, and he's really struggling and has now come to the point where we want to consider surgery. And in this case, sorry, I've just, in this case, sorry, excuse me, my computer's gone funny. There we go. In this case, I used a posterior approach in isolation using interbody cages at L3, 4, 4, 5, and 5, 1, and lordotic rods with a single auxiliary rod to give strength to the construct and restoring his overall sagittal alignment. Of course, there's lots of different ways of doing that, but I'm just showing this example. This patient here is a further example of an auxiliary rod, this time with limited interbody cages because of the poor bone stock in the patient. And I prefer, if I can, to stay away from interbody cages, certainly from a posterior approach in elderly patients. And if I do it, I prefer to do it through the front or side. In this case, I used 3 rods, and this was one of the earlier cases I did, where you'll see developed a slight proximal junctional kyphosis. And I've gone away a bit from this type of technique now because I think having a so-called soft landing is a better idea. Evidence for that, very little. But if I'm going to have a stiffer construct, I prefer to keep it distal and then towards the end use titanium alloy rods. So I think if you have a too stiff a junction or a too stiff top of construct, then the transition between there and what is a mobile spine can be too much of a cliff edge, and patients can then develop significant junctional problems, as this lady did. The kickstand technique is interesting, and every time I use it, I've done it a different way. And you'll see here a patient with coronal shift. So he's got coronal imbalance to the right. It's a half candelabra arm type deformity. And she's failed non-optimal. She's only got axial pain and a normal incidence. And so I use this kickstand technique here. And I've used it to correct the deformity, or I've used it as an adjunct at the end of a case. This time using a variable angle domino to connect onto the rod at the end with an auxiliary rod on the side. The problems with this is that around the screw here in the pelvis, the bone can be quite soft and can sometimes dive in quite considerably, but it seems to work quite well. Here's another example of a patient with a similar type of deformity, but more coronal imbalance. And again, a kickstand technique lower down, but no auxiliary rod on the contralateral side on this occasion. And here I put a brace, which is quite unusual for me, but I did that because she was had very poor compliance with the instructions on how to control her upper thoracic spine, as I didn't want her to develop proximal junctional kyphosis or failure. Here's a patient with adjacent stenosis who above a construct, which is slightly kyphotic, as you can see, and had foot drops from previous surgery, couldn't stand up with loose L3 screws and really struggling. You can see in her thoracic spine, she's compensating, and we know that because it's lordotic. And that means the muscles in the thoracic spine are working well, which is generally a good sign. So we can correct the lumbar spine, then the thoracic spine adapts accordingly. You can see here with a short construct using multiple rods and a 3-column osteotomy, a bit of the instrumentation is blacked out there. I've attained a good correction of that. And then this is a case where I've used auxiliary rods, a double-headed screw across a short construct to restore alignment in the relevant area with good effect. This is a lady who has got instrumentation in from many years ago, which is solidly fused and was fused knowingly in a relatively kyphotic position with a normal pelvic incidence. Interestingly, she doesn't actually compensate too much with her pelvis, but she compensates with other areas of her spine. And the plan for this lady was to do a pedicle subtraction osteotomy, which we performed, and then to go on to perform interbody cages through the discs above at L2-3 and L3-4, which was subsequently performed. In this case, a technical issue was with the big, rather sort of big and bulky heads, you have to chip away at bone to get the heads to sit in nicely, but that's not normally a problem and works very well. This patient came to with axial pain and again, a fairly straightforward sagittal deformity. But on this occasion, there's a high tilt with an elevated pelvic incidence. And so this patient needed a lot of more lordosis building into their spine. But I counsel you to say, well, how much lordosis do you build in? Do you say, well, because there's a mismatch of 50 degrees, we must put 50 degrees more lordosis back into the spine? Well, I'd suggest to you that if you do that in a gentleman of this age, you may actually then generate problems because he's used to being forward. He's used to being in this position. He's got muscle memory. He's got pathways going from his brain down to his spine and his legs saying where he stands. And so maybe sometimes undercorrection is the right thing to do. We just don't know. And it's the non-scientific part about what we do that I think is fascinating. And as time goes on and we have big data, we're going to have the answers towards this as much as we can. So this gentleman's been slightly undercorrected. Again, we're using auxiliary rod technique across a 3-column osteotomy, and he's doing well. But I've asked the question there, you know, you could argue that, and some people would say I should have put more lordosis in, I should have gone longer with the rod. But at this stage, he's doing well, so we'll see how he goes. Here's a lady who had an operation done for predominantly stenosis and leg pain, which she was delighted with, but then presented with symptoms from deformity, not being able to stand up or compensate. And again, you can see an increased pelvic tilt with a relatively flattened lumbar spine. Her incidence isn't particularly elevated, but she did have coronal imbalance. And in this case, the aim was to restore global alignment and her slight coronal tilt and restore lordosis, again, using the double-headed screws with a controller attached, which I'll show you shortly. And it's important to get good distal fixation to facilitate the osteotomy. It's always a challenge when you're doing a lower osteotomy to get a good fixation. And so I think you need to be very adept in being able to put in a good pelvic fixation. And if you have an O-arm, it can be really good to do that. But otherwise, there are lots of freehand techniques. And again, you can see here, I've used auxiliary rods across the lumbosacral area and the 3-column osteotomy, whereas at the top of the construct, I've used titanium alloy long rods so that there's not such a cliff edge fall off. She's delighted with the outcome. So here's a final case I'm going to show you of a patient who's had a vertebral column resection with using the double-headed screws, multiple rods, and a controller. And you can see she's had a previous Harrington rod, which has been partially removed. And because she had symptoms simply from the lumbosacral area when she first presented to me, I performed an isolated decompression and fusion to give her good benefit of her leg pain. And actually, this is something I've done on quite a few occasions. You know, you do a low construct, you do a short construct, you tend to get good symptomatic relief for patients. You make screw tracks, which are excellent when you go back in to do a long construct, you know, years later. And the failure rate of doing a short construct within the construct is actually very low compared to doing a long construct. And when you come to doing a long construct, you've got an excellent base with good screw holes to form it on. So it's something that I do think about and often do in these patients. So this situation we had a very significant very significant thoracolumbokyphosis, which is a solid fusion mass and a real challenge. And you can see I used an O-arm for this because we had a fusion mass, and I used that to place the double-headed screws, which you can see here in the patient. And when you attach double-headed screws, you can then attach the controller here, which you can see on the right, to multiple screws. And once you attach it to multiple screws, you spread the load of where you're doing your correction, which is obviously good because you get less instrumentation failure when you're closing an osteotomy down. It also enables you to work easily without having to take rods on and off, as you often would. And crucially, once you've reduced your deformity with the controller and the little knobs twiddling it, you can just drop a rod in into the second slot on the double-headed screw. And you can see here, much closer up, that we closed the osteotomy down partially. You can see the theca there. And you can see how the rod attaches to more than one screw head to distribute the load. So it's a very nice flexible bit of kit that gives you good access, easy attachment, 3D working, no changing of rods, and importantly, when you close it down, often much less translation. And here's the net result of that that I did with an O-arm and the vertebral column resection using multiple rods and the double-headed screws and the controller. So that's a real fly-through, sort of my practice and why I've started using 3 rods, 4 rods in osteotomies in particular. Not always, but it's just, you know, how things are with the nuts and bolts with me at the moment. I'd like to emphasize and maybe get away from the nuts and bolts a bit, that patient selection is always the be-all and end-all in adult deformity. That these x-rays I've shown you and techniques are just one of so many factors, and that I have no problem if people can achieve absolutely the same by doing it through the front, through the side. It's just the way I do it. And we sometimes see all these nuts and bolts and we forget biology. So don't forget biology. It's vitally important. Good blood supply, oxygen, all those things. So just a summary of my thoughts, and thank you for listening, is that go back to basics, recognize where you've got low incidence and high incidence, because you'll get your fingers burned if you don't. Recognize how a patient compensates with their muscles in non-instrumented segments. Recognize that the brain tells the spine where to go and might have been telling the spine that to be there for the last number of years. Consider lumbar shape, not just lordosis over so many segments. And don't always seek what is a theoretical ideal in a young patient, respecting biology. And if you're going to operate, I think it's right to, in older patients, to consider stronger fixation that you could cynically argue is going to fail, but fail later. And we now have lots of adjuncts to help you do 3 colonostomies, including this controller and all the supplementary nuts and bolts I've shown you. So I hope that's helpful and useful. And with that, I'll end my talk and maybe take some questions or points now. Thank you.
Thanks, Ian, for that excellent and really insightful talking to the complexities of adult deformity. Just as a note, if anyone has any questions, obviously for Ian or myself, if you put them into the chat section, and we'll ensure we answer those questions as best we can. Please just put those in now. So before all those questions come streaming in, I'll start with a few. I think absolutely right when you talk about patient selection, and a lot comes into that. And one of my questions is, what do you use to, if you like, age your patient and work out what's an elderly and what's not an elderly patient these days?
Yeah, so there's lots of scores, aren't there? You can do, and lots of programs you can put in. The Seattle Spine Core and things about frailty and comorbidities, and big data is going to help us with that. I have to be honest and say we can do all those things, but a lot of it is about the end of the bed test, discussing with family, and experience is probably the biggest thing. In fact, I've seen one study that compared a surgeon saying, did they feel a patient was a winner for surgery, compared to data telling you that they're a winner for surgery. And experienced surgeons are actually quite good at predicting what the data did. But yeah, it's true. And I've had my fingers burnt on a number of occasions by picking the wrong patient, whether it be their bone stock, their behavior, their compliance, other things to do with their health, things I hadn't recognized, that I'd been too focused on their spine. So that's a hands up, but I think we were very reliant on experience and listening and talking to others about when we pick patients.
Great, thank you. We've got a question here from Mark asking, which spinopelvic parameters do you think are the most important?
That's a great question. So I think incidence is, I mean, it's a fixed parameter in adults, give or take a few nanodegrees across the sacroiliac joint. But so I think that's a real basic thing that you have to be looking at, because if you've got a patient with a PI of, say, 80 degrees and you don't respect that, you can end up in real trouble correcting them. So I think that's the first thing, and it's a baseline. I tend to then look personally at tilt and how the patient compensates. And I don't know why some people compensate well with their pelvis and other people's pelvis just doesn't move, and they compensate with other areas of their spine or their knees. I suppose it could be due to musculature around their hip, etc. But I think that would be the second most important thing that I look at. I then look at overall global alignment. But I emphasize that although beyond the anatomic parameter of incidence, all the other parameters change, and they change when you sit, when you move, when you lie down, when you run, when you walk, when you're tired, when you get up in the morning, when you go to bed at night. They're all different. And so I think you have to be very careful about using those, and use them with at least some understanding that they move and they change. So short answer, incidence.
I mean, how to and how much to bring a patient back into the alignment that we think they should be in from all of our various measurements and what have you. And how long do you think, I suppose this is a leading question because I've got a patient I'm thinking of. I've got a patient who's only about 45, but it's been in significant positive balance since her 20s because of an interesting 5-1 fixation, shall we say. And pulling her a long way back's been quite a struggle for us, and quite a struggle for her to respond to. So I'm wondering what your thoughts on how long and how you judge that muscle memory, which I think is really important.
Well, I think it's muscle memory. So there's lots of things. There's muscle memory is one thing. It's your brain memory as well, where it's a neuroplasticity, where your brain is saying you should be, where you're used to being. And I think it's also muscle function. So when people have been forward for a long period of time, their glutes are weak, all sorts of things might be contributing to it. All I can say is that the longer you've had it, the more difficult it's going to be to get it right afterwards. And the older people are, it's going to be worse. But beyond that, I don't know. And it worries the hell out of me because, we strive to attain this ideal. And in some patients, it's just unrealistic. At the same time, you could argue if you don't get people perfect and up, then they fail. And so, you know, it's a rock and a hard place, which is the very nature of adult deformity. I think you just have to prepare patients for that and acknowledge that it occurs and that we don't have the answer. And that's just being honest with them. I think to say, you know, it's going to be perfect to a patient is not right. And you just have to acknowledge that to patients and say what's what.
Thank you.
Okay, so I think we need to move on now, don't we, Andrew?
He wants to do.
So you had one more question, did you?
Do you want to just answer that last question?
Go on. What was the question?
So yeah, we've got Amit has a question. The question is that he wants to do a T1 to T3 fixation and remove a tumor.
Yeah.
And he's wondering, when you operate high, hooks or screws, essentially.
Whatever you want. If you can get a good hold in the bone, and that's what works for you in your hospital, then do that. Personally, I wouldn't use a hook in that situation, but historically and in a tumor, it may be very appropriate to do if it's, you know, a short-term lifespan, etc., just to get the patient stable and palliate. Okay, so I think we should now move on to Andrew's talk, shouldn't we? So, Andrew's a colleague up in diagonally opposite me in the country, and he's going to give you a talk on something altogether different: paediatrics.
Thanks, Ian. Yes, so a change in age group quite considerably. Obviously, similar problems can be an issue, but a very different population. As Ian mentions, I'm up in the north. So the pandemic has obviously changed a lot, and not only do what we need to do in the near future with our patients, but with training and lots of different things have been altered by this pandemic. So it's a great opportunity, I think, for us as a community to change practice, to challenge current practice and thinking, and to really see what we can do to improve the situation as we come out of it. On the flip of this is obviously that prior to the pandemic, we were getting surgical care. Not enough people were getting the surgeries required. And because of that, a number of patients are dying because they're not getting access to surgery. Obviously, that's less of an issue with us as orthopaedic surgeons, but clearly theatre space is a commodity, and therefore we need to work out how best to use that. Similarly, we can also, plenty of data, and I'm sure we know from our own experiences that a lack of experience or poor surgical skills ultimately leads into poor patient outcomes. So what can we do to try and mitigate this? Because clearly we've been doing training and education relatively similarly for a very, very long time now. So what can we do to kickstart change that to really improve future outcomes? So the potential strategies for this, I think we are thinking out of the box now. Obviously, is the remote consultation, which a lot of us have been forced into doing because we can't do face-to-face outpatient clinics anymore. How do we pre-plan our operations so that when we do get into an operating theatre, we actually do the best operation possible and therefore potentially get the best outcome for patients? And as Ian mentioned before, this term big data is something that will be bandied around a lot and increasingly over the future years as we try to learn from everyone in the world, or everyone at least that can put into our data sets to help us work out what to do. Obviously, if we can do procedures that have shorter length of stay in hospital, that frees up hospital beds so we can do more operations. And we need to look at novel ways of training, and potentially, I'm certainly very keen on robotics, and I'm sure a number of people are very interested in robotics, even if they don't want to use it themselves. Certainly they see that robots are coming and we need to engage with the concept. Challenges to this, obviously, we've got our current issues with being socially distanced, as tonight exemplifies. We can't travel to view and learn together like we normally would do. Cadaver labs obviously are very limited, and we just can't travel around to do things. Similarly, we need to capitalize on changes happening. Zoom have doing better than the airlines these days, because obviously they can be used in a pandemic. But as mentioned, we've got this potential idea for remote access clinics. A lot of patients are going to have to come to a different way to clinic, different ways to follow up to ensure that we provide excellence in healthcare. Another way around this is obviously we can look at how we train ourselves, and particularly we can use and look to virtual reality for the first time, I think, in a sensible way for surgical training. Pre-operative planning is clearly very important. A lot of us with very complex cases would do CT scans, and we'd render these to work out exactly what we can and can't achieve, find out and understand the anatomy fully, which is very, very helpful. It's easy, it's quick. If you have access to 3D printing, again, you can use these 3D prints, which I think is really important, and certainly in my hands, because I'm a very visual person, I think like a lot of surgeons are, by holding a model in your hand, you understand the anatomy better. Potentially you can even take your saw to this and do the osteotomies you require in advance, so good way of practicing. But again, we can utilize the VR virtual reality platform, so you can spin this model around in your hands virtually, which is obviously a lot cheaper and a lot easier, certainly if you don't have access to 3D printers.
Sorry,
I think there's a lot of talk at the moment.
Sorry to jump in.
Hello?
I think the connection on your end is a bit slow. Do you reckon you'd maybe be able to just stop sharing and just restart sharing, please? We just some people are not able to see the presentation clearly.
Try that again.
Yeah, if you
so
just
I
change
won't
it.
speak slower. I don't think that makes the connection work better.
Change it off.
But we'll see. Hopefully this will be improved. So is that still not working?
Mr. Bowie, I think you have your presentation in video quality. So, and usually that hampers a bit the quality of the projection. Maybe you can swap it for normal sharing, and then when you share the video, you swap it again.
Great, so I've turned that off. So looking towards new techniques potentially, and there's a lot of talk about this at the moment, which is growth modulation. And I think this is a really interesting way for us to satisfy some of those needs and criteria that the pandemic has actually shown for us. So Medtronic have developed the Brave system, which is a growth modulation system, and that's key to this. It's trying to drive the correction of the spine through the growth of the spine. We're not pulling the spine straight, and we're not trying to get a correction in a non-fused spine. We're trying to allow growth to drive this change. Again, techniques, it's obviously a less invasive operation. And we all know that less invasive operations ultimately lead to shorter length of stay, which is really important at present, but also a shorter operating time, potentially leading to us doing more surgeries in the same day, which again, due to a backlog, certainly in the United Kingdom, is going to be imperative because we are a long way behind after having a number of months away from normal elective surgery. The BRAVE technique is based on the Hoyte-Voltman principle, which we hopefully know well from our orthopedic training. So there's some science behind what we're trying to achieve here. And the other benefits are we have a clear inclusion criteria, which I'll go on to, as to what we think is appropriate for these patients. Hopefully a lot of us have access to O-arm navigation, which again makes this procedure a lot more straightforward. And as mentioned, pre-op planning, really important, and there is a BRAVE sim for it, and some education along with this. And furthermore, we've developed a virtual training platform to upskill surgeons in this quite novel technique if surgeons aren't used to thoracoscopic skills. So it's a CE mark product, and it has been launched in Europe on limited release at present. As mentioned, the clear criteria is that these are for idiopathic type curves. It's for the immature growing skeleton, and therefore they need to be RISA 0 to 2 and a Saunders of 2 to 5. And therefore flexible, moderate curves of 30 to 60 degrees, which is really important. These aren't for big stiff curves. The BRAVE Nav, as I mentioned, when we're doing a thoracoscopic technique, it's hard enough to try and work out where you are in the thoracoscopic place if you're not used to it. And then if we can take away the need for fluoroscopy intraoperatively and replace that by using navigation, it makes it a lot more straightforward. As you see in the center of the vertebral body, which is important, as these thoracic vertebrae are quite small and soft, and it ensures we get the right length so we can develop a bicortical fix, which is what we want to achieve. As you see here, the bicortical fix ensures that better hold on the bone, and as it's a blunt screw, we're not causing any damage on the unseen side, which we can't access readily. The predictive modeling, which I think is useful for the surgeons as an educational tool, but also for the families and the patient, because ultimately we know that patients aren't going to be straight day one. This is a 2-year process. We want the spine to grow and the spine to straighten. So often, you know, as we see from our normal posterior fixations, when the patients get x-rayed 3-4 days afterwards and they've got a beautifully straight spine, they're delighted and off they go. In this case, obviously, they're not going to have a completely straightened spine. So to avoid mass disappointment on the patients and the family side, at least this way we can help put in the data and tell the patient what they're going to look a year after, and indeed 2 years after the correction. And by putting in different upper and lower levels and different amounts of correction achieved on table, we can show and predict how the spine will behave. And again, that helps us work out if we can save a level or if we need to add a level, or indeed potentially if this patient isn't going to be suitable for the technique, which is clearly important because we don't want to be putting patients through a surgery that isn't going to work, which would be the case in the much higher stiffer curves. Some more examples. So moving forward to virtual reality training, I think that's going to be something we see more and more, partly because surgeons' time is going to be taken up by catch up from the pandemic, but also the lack of activity and lack of access to foreign cadaver labs and training sessions means we're going to have to do a lot more in hospital, and not all hospitals are fortunate enough to have all of the training facilities we need. So here we can see this is a very useful technique in trying to place pedicle screws. This has both American and it's a very useful way to practice placing pedicle screws, potentially just as good as a cadaver, and the feedback is a lot better than a cadaver because it's not as soft. So certainly there's some benefits to this. Furthermore, your trainees can practice time and time again. A leaderboard can be created, and surgeons tend to be quite competitive people, and therefore will probably spend a bit longer trying to get that perfect screw position to try and beat their other residents. So this is an example of what we've developed. So when you go for the Brave training tool, you'll get this set-top box, which in itself doesn't look much like a spine. But as soon as you put the virtual reality headset on, you start to see what the world looks like in the operating theatre. You can alter the image depending on the level of need and training need of each surgeon. And then again, that helps us to find out where we are. So I'll play a short video now. And important when you first walk into the virtual world, it's important to look around to get your balance, to get your point of reference, because it can be a bit disorientating. So it's a good idea to have a good look around and play with the various things in the room, such as the table and the operating lights and what have you. And then you can start to add what you need. So you've got your patient, and then obviously the equipment that you need for the operation itself. And by doing this, you only need a few tools rather than the tools you need for the procedure. So a familiar general handle, and then you can just pick up a screwdriver. Obviously, you're not picking up too much in real life, and that allows ease of training and ease of replication, because you could, take this home. It doesn't need to be done in the hospital. And just working through the various Brave tools, including the counter torque that we're very used to, they're all to start off the screw. And we'll see also that we've got the Brave grasper. So this is to grasp the cord, but we're in the process of developing a more usable version of this to counter torque that while it's tensioned into the patient's spine forward. As you see, we've got all the various bits and bobs we need for the operation, all available in the virtual setting. So it just gets the hand-eye coordination sped up a bit for when you start this technique, if you're not too used to the thoracoscopic approach. And really, you can start the operation at any point. So if you're used to putting the portals in, that can be done for you. And you just step into the part that you need, such as placing the screw into the vertebral body. And it's important that we also mimic the use of X-ray to ensure that you also know you're at the right level and in the right part of the spine. So the virtual world, although it's very bright, isn't too dissimilar to the slightly dark real world, but certainly you can see all that you need to see for the procedures. Furthermore, we can practice this remotely, so surgeons can watch other surgeons, whether that be beamed into a live room or just beamed into a cadaver lab, and therefore we can, through this connection, certainly upskill each other to ensure that we're all trained appropriately, and the training can happen all around the world with everyone dialing into it, as similar to how we do via Zoom. One of my colleagues in Liverpool was the first to use these, allowed to have Medtronic staff to help support a case because of restricted activity in the theatre due to the COVID crisis. So therefore his rep was able to help support the case remotely. But clearly the step from this is that surgeons can help train other surgeons remotely as well. And indeed, other things can be placed onto the smart image, such as the robotics tools and also navigation itself. And robotics, clearly, as mentioned, it's going to be a great advance in the future. And as Ian mentioned before, pre-op planning is really essential as to what we're going to do. So that's going to drive more surgeons to plan in advance and really think about what they're going to do and what they're going to achieve. And that makes it more patient specific. Obviously, the improved accuracy we presume from robotics and the reduced radiation dose to ourself, which is really important. Certainly if any of us do percutaneous, well, this takes that away. And training and manpower, obviously in the States, access surgeons are quite commonplace, but once we get more used to robotics, there's no reason we can't have screw placement technicians rather than surgeons doing it. And therefore we could move around to more theatres at once and have other people who've not been through a 20-year training program, but maybe just 1 or 2 years of practicing screws. But this clearly creates a digital journey, which is really important. So we know where and how much time is spent on each part of the operation. Currently, most people just collect data on when they go into theatre and when they go out to theatre. And clearly a lot can happen in that time. So a lot can do to improve, although we'll have to ensure we've got better internet connectivity to be as forward-thinking as we'd like to. Allows some remote access work, but we need to look at new techniques and novel techniques. Obviously, screw placement is going to be paramount to the majority of scoliosis procedures, but does it just have to be a posterior fusion, or can we consider other techniques like this growth modulation through the Brave technique? Finally, robotics, as we mentioned. And then just as a sort of a throwaway comment right at the very end, is that we can start to look at patient-specific implants. We all spend plenty of time bending rods, but we know that they flatten out. They aren't bent potentially always in the right place. As Ian mentioned, not everyone's lumbar lordosis finishes at L1, and therefore bending them more accurately potentially is going to help us. So I think that will be my part done. So we'll see if there's any questions for me now.
Andy, while we're waiting for any questions to potentially come through, can I just ask you about your own experience of this sort of reality stuff and what feedback you get and what biofeedback you get and how it compares to the real thing?
Yeah, so it depends on how good your equipment is, like a lot of things. If you're just basically putting a headset on, that's very, very light reality, I would say. And it gets your hands in the right way. The key to any really useful virtual reality platforms, the haptic feedback. And that's really where the new developments are coming to make it actually more worthwhile. And a few of the pictures showed there, we've got the haptics now, and you do get that feedback when you're pressing on bone. It feels like you're pressing on bone. I did a hip replacement virtually the other week, and although it's been a while since I did a real one, it didn't feel too dissimilar. So it's the new haptics that are really going to be a game changer for this.
Yeah, exactly. I mean, I think that for me, that's the thing. I mean, it's all well and good just having the tool in your hand, but actually the feel is the right thing. So that sounds pretty exciting. So doing a hip replacement is amazing. I mean, when you think how tactile that is, it's like a real feel thing. And it's amazing to do that. Can I just ask about the technique specifically? And a question about how you align sagittally with a bit of rope. What can you do to try and control sagittal in these patients, or do you just ignore that?
No, you do look at that, and you can place the screw either more anterior or more posterior around the apex, depending on how much rotation you think you need to try and correct. It isn't as good at full correction of sagittal profile problems, but also we're mindful that these are small flexible curves of around 30 to 60 degrees, which tend to not have quite as much rotation involved with them. in that these are younger kids with that size curve. You know, it's kind of a 10-year-old with their 30 to 60 degree curve, and they tend not to have quite that huge rib hump that we see in the, you know, the 16-year-old with the same size curve.
Okay, so we've got a question here from Dr. Kumar. And I'll read the question. I think I understand what he's getting at. It says, if a child is having a cervicothoracic and a thoracolumbar kyphoscoliosis simultaneously, do we need to stage the surgery? So it's a pretty generic question. And he says the child's age 9. I would have thought the answer is, I mean, I'll let Andrew, but I'd say it depends.
Yeah, absolutely. I suppose if we're hitting the age of 9, we're assuming that this isn't, this correction's not going to particularly interfere or improve lung function as the lungs kind of develop now. So we've moved away from sort of the growing rod constructs. I guess that's the first point to be mindful of. Again, staging it would, in my hands, I tend to stage surgery only if I think things need a release, and then I put them on traction for a time. Often a significant curve in a 9-year-old means that there's a lot more going on than a straightforward idiopathic curve. And ultimately what is the outcome? Because the outcome doesn't always have to be a straight spine. It's just a balanced spine that allows the lungs to develop.
Okay, if we're not getting any other questions, I'd just like to ask another one, which is something that I've seen. I just wonder if you do, Andy. Do you ever take the discs out doing this technique? And I've particularly seen it in the older patients with a bigger curve. Have you done that or experienced that?
Yes, so in this technique itself, you leave the discs well alone, because the worry is that once you interfere with the disc, you then cause it to fuse anteriorly.
Yeah.
In my hands, and the reason I'm pushing this technique is that I use thoracoscopic discectomy in the big stiff curves. So also anyone with a kyphosis, so in any Shermans I fuse, I tend to always take the discs out anteriorly. And likewise, if I've got a stiff curve over 90 degrees in a kid, not too high a curve, because once you can't really get above T5-6 often.
Yeah.
So you can't get those high curves, but certainly it's very good for releasing the spine to get a better correction in the larger, stiffer curves.
Okay, it's great. Well, it's very exciting technology, that's for sure. Certainly a lot more exciting, I think, than adult deformity. Just lots of problems.
I don't know.
Anyway, so I think we're going to have to tie it up there. Time has come round already. It's flown by. So there's no further questions. And thank you for inviting us, Medtronic, and have a good evening wherever you are in the world.